To start, let's briefly frame vascular Ehlers-Danlos syndrome. It's a rare, autosomal dominance arteriopathy fundamentally defined by a pathogenic variant in the COL3A gene. This gene, of course, is critical as it encodes the alpha-1 chain of type 3 collagen. The classical clinical picture involves a fragile skin, easy bruising, and sometimes facial dysmorphism. But the pathology that brings these patients to our attention is the high risk of spontaneous arterial aneurysm and dissections. As we all know, arterial rupture is the primary cause of mortality here. The incidence is 25% of patients will have a complication before age of 20, and that rises sharply to 80% by age of 40. Let's move to our first case. She was a 23-year-old female with no prior history of major events. This is a critical factor. The event can be entirely spontaneous. There was a relevant family history though. Her maternal aunt had survived a mesenteric artery dissection. She was later confirmed to have the pathogenic variant called 3A1. Her subsequent course truly demonstrates the multifocal nature of this disease. When the patient first presented, it was acute and severe, sudden onset right-sided abdominal and flank pain. The initial CT angiography revealed extensive multifocal arterial pathology. Note the sheer number of events: acute thrombosis of the right renal artery resulting in a large infarct, splenic artery thrombosis, and focal dissection in celiac, right renal, and external iliac artery. To manage the renal event, she underwent catheter-directed thrombolysis of the right renal artery. Just 1 month after discharge, we saw significant progression. The follow-up imaging revealed a new type B aortic dissection with aneurysmal dilation of the juxtarenal aorta, plus a separate new dissection in the infrarenal aorta extending to the bifurcation. The disease is clearly rapidly evolving. Clinically, she exhibited the classical physical exam finding the wide atrophic scar, thin translucent skin, and hyperextensible elbow. Her management plan involved medical therapy, the beta blocker carvedilol, and initiating an intensive serial surveillance protocol with head-to-pelvic imaging. 4 months into her surveillance, recurrent abdominal pain indicated an issue. The splenic artery aneurysm had significantly increased in size to 2.3 centimeters, prompting an elective splenic artery embolization. However, immediately post-procedure, the CTA revealed a critical complication, a new dissection at the common hepatic artery and gastroduodenal artery bifurcation, resulting in a GDA occlusion. This single event powerfully illustrates the extreme arterial fragility of vascular Ehlers-Danlos syndrome patients. Even necessary, planned intervention carries an inherent risk of propagating new dissection and pseudoaneurysm. 3 months after the embolization, the progression continued. This time, presenting as a recurrent neck pain, the CTA demonstrated new disease in the cerebral arteries, bilateral vertebral artery dissection, and left internal carotid artery pseudoaneurysm. Given the high risk of intervention in the cerebral vasculature, the multidisciplinary team opted for conservative management, discharging her on aspirin. This is a challenging trade-off we face constantly with the vascular Ehlers-Danlos syndrome patients. This patient's course encapsulated the management dilemma perfectly. Just 3 weeks later, she returned with an acute thrombosis of the dissected proximal right vertebral artery. She was started on anticoagulant apixaban. However, apixaban had to be discontinued only after 5 weeks due to an episode of GI bleeding. This clearly emphasized the management tightrope. balancing the prevention of life-threatening thrombotic events versus the high intrinsic risk of catastrophic arterial hemorrhage. Moving on to our next patient, a 35 years old male with pre-existing hypertension. He presented with chest pain. Imaging revealed a cameral diverticulum with aberrant right subclavian artery, along with the type B aortic dissection extending from the aberrant right subclavian artery to the aortic bifurcation. His initial course was complicated by severe sepsis, pneumothorax, and required thyroidectomy with trichostomy. He was discharged 38 days later on lisinopril and carvedilol. Following his discharge, patient was unfortunately lost to follow-up for routine surveillance, and his chronic systematic hypertension remained uncontrolled for a period of 6 years. After 6 years, the patient presented again with acute abdominal pain. The CT at this time revealed a significant disease progression, a new 4.7 cm infrarenal abdominal aortic aneurysm. His distal arc and the proximal descending aorta had dilated to 5.4 cm. His symptoms resolved quickly with medical management focused on blood pressure control. This highlighted that while the vascular Ehlers-Danlos syndrome is the underlying pathology, the acceleration of aortic disease is likely driven by secondary factors like chronic uncontrolled hypertension. At this stage, genetic analysis confirmed the COL3A1 splice acceptor variant. This haploinsufficiency variant is often associated with a milder delayed onset phenotype. However, the combination of vascular Ehlers-Danlos syndrome with his congenital anomaly and uncontrolled hypertension led to rapid severe progression. A two-stage open repair was planned, right subclavian bypass followed by descending aortic repair. The surgical plan was executed in this stage. The first stage, a right subclavian bypass, was complicated by a phrenic nerve palsy. The definitive thoracoabdominal repair was then delayed for 4 years due to recurrent respiratory issues and heart failure. When he finally returned, the aorta had continued to dilate to 6.5 centimeters. He successfully underwent open replacement of the distal transverse arc and descending thoracic aortic aneurysm. The patient course underscored the profound impact of coexisting congenital anomalies and uncontrolled risk factors in vascular Ehlers-Danlos syndrome, often leads to requirement for complex stage open repair. I'd like to leave you with 4 concise points summarizing the critical lessons we learned in these complex cases. First, vascular Ehlers-Danlos syndrome is unpredictable and multifocal. Arterial events develop spontaneously across multiple vascular beds, requiring a high index of suspicions. Number 2, arterial fragility is the key. The tissue fragility substantially increases the risk of new dissection or pseudoaneurysm during intervention, mandating cautious surgical planning. Number 3, management is nuanced. Decisions regarding antithrombotic therapy are complex, requiring careful consideration to balance the risk of thrombosis versus the high risk of catastrophic hemorrhage. And lesson number 4, a multidisciplinary surveillance is mandatory. Vascular Ehlers-Danlos syndrome patients require lifelong follow-up and frequent surveillance imaging, CTA or MRA, within a multidisciplinary framework to manage risk factors and optimize outcome.